So first we're going to tackle the CVP waveform. We have to have our equipment first, so we need the cardiac monitor with the waveforms. We need to have a central line in the patient so that we're able to monitor the right atrial pressure or central venous pressure. We need to have the transducing tubing and pressure bag, and then we need to have the ability to compare the EKG to the central venous pressure or CVP waveform. So if a patient were to have a Swan-Ganz catheter, which we're not doing here in the ED, you would see the catheter tip, the recording portion of it, be actually in the right atrium. We're doing central line monitoring, and the central line tip is going to be at the opening of the right atrium, so in the superior vena cava. And what those are measures of is the patient's intravascular volume or right ventricular preload. All right, before we even tackle looking at the numbers on the monitor or interpreting the waveform, we need to make sure that the transducing system has been leveled and zeroed. It's leveled and zeroed to the patient's right atrium. So we're looking for the phlebistatic axis. The phlebistatic axis is the point halfway in between the patient's anterior and posterior chest at the fourth intercostal space. And then you line that up with the stopcock, which is the air fluid interface, and then you are going to zero it. All right, let's talk about the components of the CVP waveform. There's three peaks, the A, the C, and the V wave. And then there's two descents, which are the X and the Y descents. All right, so the one that we really want to pay attention to and be able to recognize is the A wave. The A wave represents atrial contraction, and you need to have the EKG above or below it so that you can see where the A wave falls in relationship to the QRS complex. So the A wave corresponds to the PR interval. So you know that when the atria contract, when the SA node fires, you see the P wave, and then that makes the atria contract, and that's the electrical component. So as that pressure wave travels through the transducing system and then finally to the monitor, there's a little bit of a lag. Therefore, the A wave is just slightly after the P wave. All right, and then there's the C wave, which represents closure of the tricuspid valve, and it correlates to the QRS complex. And then the V wave, which is atrial filling, or bulging of the atria, bulging of the valve into the atria, and that correlates to the TP interval. Okay, so why do we care? Because if you look at the waveform, you see that there's a whole bunch of little squiggles. And again, the importance of monitoring the CVP waveform or interpreting it is that we're finding the A wave, and we're going to take the mean of the A wave. So you wouldn't want to take a mean of the V wave or the C wave, because that wouldn't be the accurate reading that we're looking for. All right, and then the two descents. The X descent represents atrial relaxation, and then the Y descent is the tricuspid valve reopening. Here's another quick little diagram of what is happening to the waveform as the blood is being pumped through the heart. So in the bottom left-hand corner, you see the A wave, what's happening there, and as the atria are contracting and creating that pressure, you get that big pressure wave of the A wave, and that again is. All right, respiratory variation has an impact on our waveform interpretation. We want to measure our waveforms at end expiration. So if your patient is ventilated, or if they're spontaneously breathing and you have respiratory variation, so the up and down movement of the waveform on your printout, your numbers are going to be different, and where you evaluate your A wave is going to be different. So how I remember this is for ventilated patients, V valley vent. So you're going to, end expiration is going to be at the end of the valley on ventilated patients. And that's because on a pressure type of ventilator, the air is being forced into the lungs. And then for the spontaneously breathing patient, I like to think of these as mountains. So we're going to measure end expiration at the end of the mountain, or before the mountain starts to slide back down into the valley. Of course, putting your hand on the patient and looking at the waveform is always a great way to verify that that indeed is end expiration. So note, especially when you have respiratory variation, as your patient's breathing, your hands on their chest, you're looking at the waveform. Okay, on my vented patient, yes, indeed, the V-valley vent is applicable, and I'm going to measure the mean of my A wave at the end of the valley on this patient. All right, now to the fun part. How do we accurately determine the CVP? So first of all, just like we talked about, you need to make sure that your patient is properly positioned. So you've leveled and zeroed the air fluid interface to the patient's phlebostatic axis. Then you're going to run a dual channel strip of the EKG and the CVP so you can compare the two. You're going to measure the CVP at end expiration, and then you're going to draw a line. You need to isolate that A, C, and V wave so you know which one is the A wave. You're going to draw a line from the beginning of the P wave down to the CVP waveform, and then you're going to do it one complex over. So now we've isolated the A, the C, and the V wave. And then we're going to align the PR interval with the CVP waveform and then identify our A wave. So there it is. And then we need to look at the scale and make sure that it's not too big or not too small. And then we're going to draw a line from the middle of our A wave all the way over to our scale, and that is our CVP number. So in this case, it looks like around 20. Here's some quick little CVP fast facts from this great website, Life in the Fast Lane, about what affects CVP numbers. So volume status, anything preload related is going to affect your numbers. And then what causes a raise in your CVP. The big one to pay attention to is our high PEEP settings could definitely affect it. And then anything going on with your heart there, fluid overload. Some more fast facts about accuracy of your CVP placement, just as a reference for you, are all listed there as well. And you can refer back to them later. All right, so what are the highlights of interpreting your CVP waveform? You want to level and zero to the patient's phlebostatic axis. The point that you're using is the stopcock, the air fluid interface. And then you're going to measure at end expiration. Pay attention to if your patient is on a vent or they're spontaneously breathing. And then you're going to measure the mean of the A wave. All right, here's some practice. So let's isolate the A, the C, and the V wave. They're labeled for you as well. I've done it for you here. Let's draw a line from one P wave down to the CVP and then over to the next and identify our PR interval. And then our A wave is right there. If we draw a line across, what do we get? We get a CVP of, again, about 20.